Okay, so we are continuing with chapter 12. This is part 2. I believe where we left off here at loop diuretics, and we are discussing side effects, adverse effects. We talked about how ototoxicity is one of the major side effects. So some patients do experience hearing loss, so you want to make sure you memorize that, as well as the fact that it can cause hyperglycemia. A thing to be said about loop diuretics and taking other medications. So, sometimes there's contraindications when taking two different medications or more. So one of the complications that I want to discuss, or the drug interactions that I want to discuss, is the ingestion of NSAIDs with loop diuretics. Ingestion of NSAIDs to loop diuretics. NSAIDs, which are non-steroidal anti-inflammatory drugs that at this point we've already learned about, they interfere with the GFR in the kidneys, or the glomerular filtration rate. In other words, it interferes with the filter in the kidneys. And if the filter isn't working, it'll allow large particles such as protein and blood and other things that don't belong in it to pass, which essentially damages the kidneys. So you want to watch patients who are on loop diuretics who are also concurrently taking NSAIDs. Alright, so we're going to check before, of course, electrolyte levels, because we want to make sure that their sodium and potassium levels are in checked ahead of time. Also, we want to make sure that we are aware if the patient is taking other drugs that cause ototoxicity, because we know that loop diuretics cause ototoxicity, and we don't want to increase the chances for the patient to experience hearing loss. So after we administer loop diuretics, we want to give potassium supplements as ordered, because it will be lower, and we want to monitor for hearing loss. So if you check before, you get the baseline of what they can and can't hear, and you check after to see if there are any changes to know if the loop diuretics is actually the cause of their hearing loss, versus maybe they had hearing loss beforehand, something like that. Patient teaching, again, I just want to remind you, the very thing that you need to know as a nurse is the very thing that you want to educate your patient on knowing. Again, you just want to explain it to them in layman's terms. So you want to have them limit alcohol and limit their exposure to the sun. I assume some of this causes photosensitivity. You want to also encourage them to take potassium supplements and or increase potassium in their diet, be it bananas, potatoes, etc., and report ototoxicity. So lifespan considerations, for older adults, of course, they're more sensitive. Dizziness, lightheadedness, and falls are more likely. Again, they have diminished cardiovascular volume, so of course they're more prone to this, and they're more prone to dehydration or symptoms of dehydration, because at their base, or at their baseline, they're already diminished with their cardiovascular volume. Also, blood clots and hypokalemia is likely. So we have potassium sparing diuretics. These diuretics prevents the kidneys from losing potassium. So if you recall, when we discuss other diuretics such as thiazides and maybe loop diuretics, that pretty much they manage or dictate how sodium and potassium, for that matter, goes in and out of the tubules. Either it's reabsorbed because we need it, or it's excreted because it's too much. And potassium tends to follow that same pattern. But with potassium sparing diuretics, it has the opposite effect. It actually conserves potassium. And some examples of those drugs are spirolactone, trimetrine, and amiloride. Really important that you know specifically these drugs. Spirolactone you'll see a lot in the clinical setting. Understand that it does conserve potassium. So what are we going to be concerned about? Hyperkalemia. We want diuresis without potassium loss, and that is up to the physician to decide which diuretic he wants the patient on for whatever reason. That's not your problem, you know. Side effects: postural hypotension and hyponatremia. Adverse effects: fainting or falling, and hyperkalemia. You also want to make sure before you give potassium sparing diuretics that you check the electrolyte levels before, for obvious reasons. No potassium supplements should be given to these patients because they are already conserving potassium. So if you give them potassium supplements, it's only going to increase their potassium levels. Don't give them salt substitutes either, because salt substitutes contain massive amounts of potassium, and so you will inadvertently tell the patient, hey, salt substitutes are fine, but if they're on a potassium sparing diuretic, you are actually increasing their potassium level. And also with ACE inhibitors. Let's see. So no ACE inhibitors. ACE inhibitors suppress angiotensin II, which leads to a decrease in aldosterone levels. And aldosterone is responsible for increasing the excretion of potassium. So therefore, ACE inhibitors can conserve potassium. And that's why we won't give ACE inhibitors to patients on potassium-sparing diuretics. So again, you want to check after the fact. You want to monitor for hyperkalemia to make sure that it hasn't elevated or increased. Again, patient teaching, you want to avoid excessive amounts of high potassium and no salt substitutes. Older adults are more sensitive. We already know that. Okay, switching gears. The second part of chapter, although this is the second part of my lecture on chapter 12, this is the second part of chapter 12, which changes the subject a little bit. It talks about overactive bladder. An overactive bladder is the sudden involuntary contraction of the muscle in the bladder wall, which causes a sudden unstoppable need to urinate. So the treatment, we have Kegel exercises, and I'm sure women who've had babies, if you've ever attempted to, male or female, ever attempted to urinate in the bathroom and you were able to stop and start your flow on your own, you are utilizing those muscles to perform Kegel exercises, or your Kegel muscles. We also do bladder training, which is taking them to the bathroom every 2 hours or whatever the schedule is, and drug therapy. It could be a combination, one or the other. And so usually we give drugs for OAB, or overactive bladder, urinary antispasmodics. So let's talk about the normal bladder versus the overactive bladder. So this whole, let me see. You see how your bladder is like a hollow organ, so to speak. And all of this is muscle, and that muscle is called the detrusor muscle. It is connected to your central nervous system, so it is voluntary control, and sometimes if there is a neurogenic problem, such as patients that have like spinal cord injuries or something like that, where you know they have an issue with their spinal cord, it could be a neurogenic problem as well. So, or an involuntary problem. So let me say that again. The detrusor muscle is under voluntary control unless you have a problem with your spinal cord, such as patients with spinal cord injury or some kind of brain damage, where in that sense patient will have involuntary control of their bladder, and therefore, you know, things will happen when it doesn't want or need to happen. Okay, so what happened is this muscle will contract when the bladder is full, indicating the urge for the patient to go to the bathroom. And in the overactive bladder, the detrusor muscle contracts before the bladder is full, which will keep sending signals to the patient that they have to go to the bathroom. They have to go to the bathroom. So, and if you're experiencing this, this is really uncomfortable. So, some of your urinary antispasmodic drugs, for example, oxybutynin, which is Detrol, it's like a little blue pill. You will see that a lot, definitely a lot, in at your job wherever you work, and also you'll see this at clinical too. The other drugs are good to note as well. Intended responses, it decreases or decrease urinary frequency, urgency and incontinence. Side effect, dry mouth and eyes, headache, dizziness, and constipation. Adverse effects, chest pain, fast or irregular heart rate, shortness of breath, swelling, and rapid weight gain, confusion, and hallucinations. So before you start, you want to check blood pressure, heart rate, baseline vitals, assess for edema, establish a history for liver or kidney disease, or if the patient has glaucoma. After administration, you want to check the blood pressure, heart rate, and daily weights. Patient teaching, take on an empty stomach with water. Take missed dose when remembered. Skip if too close to next dose, and avoid becoming overheated or dehydrated. Okay, older adults may be more sensitive to drug effects, may need lower drug dose. Benign prostatic hyperplasia, or BPH, is the enlargement of the prostate gland. Symptoms include increased frequency of urination, nocturia, hesitancy, reduced urine stream, feeling of incomplete bladder emptying, and dribbling. And we have drug types. DHT, which is dihydrotestosterone inhibitor. Basically, DHT is an enzyme in adult men, and it is responsible for the male hormone that produces prostate. It produces hair for men, which if they have issues with that, they'll tend to have male pattern baldness, etc. A DHT inhibitor can decrease the male hormone, which will prevent the overgrowth of the prostate cells. In the case of benign prostatic hyperplasia, hyperplasia is the excessive growth of cells, which causes it to enlarge. So by giving a patient DHT, we are preventing the prostate from enlarging. Okay. And since there are adrenergic receptors in the prostate, the next drug would be to give a selective alpha-1 blocker. Alpha-1 is a adrenergic drug, and so if we give an adrenergic blocker, we will reduce the symptoms of BPH. Notice how the prostate is nestled right under the neck of the bladder. In a normal prostate, it is relatively smaller on either side. It's a whole bulb underneath the neck of the bladder. It's posteriorly located. However, if it were to enlarge, it would begin pressing on the neck of the bladder, which decreases the area that the urine has to flow, and so the patient will have those symptoms. The intended responses of DHT inhibitors and alpha-1 blockers is to decrease in pressure, improve urine flow, and decrease BPH symptoms. Side effects: decreased libido, lowered blood pressure due to the alpha-1 blockers. Adverse effects of DHT inhibitors is that it can adversely affect other hormonal or sexual tissues. So if it affects one, it affects the male hormone. And the male hormone is responsible for testosterone production, hair production, so it'll affect other things.